Good afternoon. Today we will be discussing about the various stomach pathologies. Already one class was supposed to happen yesterday, including pyloric stenosis and IHPS and other stomach pathologies, but it got postponed. So this is the second part of that same class. Today we will be discussing regarding pathology of gastric volvulus, gastric perforation, and techniques of feeding gastrostomy. Coming to gastric volvulus, it was first reported in 19th century by Bertie. So gastric volvulus as such, it is rare in children, but it is mostly seen in age group less than 1 year and also in neonates. Coming to the anatomy and etiopathogenesis of gastric volvulus, the stomach is a well-protected structure. It has various supports to preserve its position in abdomen. So the various supports of stomach which are present are, one is a gastrophrenic ligament, the other one is a gastrocolic ligament, and also the retroperitoneal fixation of the duodenum, and also the short gastric vessels plaster stomach towards a posterior abdominal wall. So it is unlikely that the volvulus can happen. And volvulus will only happen when one of these structures gets damaged or if there is any pathology in all these attachments. Pathologically, it can also happen secondary to various other conditions. That is, one is eventration of diaphragm or along with CDH, or in case of any congenital bands which pull the stomach, and secondary to which the normal anatomical supports can become lax. So these are the so in these pathologies, stomach volvulus comes as a secondary presentation, and also in case of wandering spleen and when the gastric attachments are elongated, when it is lax, there is high chance for stomach to volvulate around its axis. The clinical presentation as such, the famous triad of Bocard, that is epigastric distension with abdominal pain and inability to pass NG tube and non-productive attempts at vomiting. So this is basically seen in adults and also in bigger children. But in neonate, as such, when we think about the clinical presentation, acute volvulus can present as cyanosis, respiratory distress, epigastric pain, and also non-bilious vomiting, and with upper abdominal distension. Another entity is chronic volvulus. It can present as an acute presentation, or it can also happen as a chronic pathology. In case of chronic volvulus, the child can present as feed intolerance and also intermittent non-bilious vomiting and growth failure. The thing with chronic volvulus is that there are two types of volvulus as such. One, it can be an organoaxial rotation or it can be a mesenteric axial rotation. In case of chronic volvulus, mostly it is an organoaxial type of twisting. And chronic volvulus mainly occurs due to a primary etiology. That is, primarily the supports of the stomach is lax. So these are the various types of gastric volvulus as shown in the picture. The picture A is depicting an organoaxial twist or a volvulus of the stomach, and picture B is depicting a mesenteric axial. So it is along the axis of the mesentery. So the stomach is getting twisted along the axis of the mesentery in an upward manner. Whereas in the first case, in case of organoaxial, which is more common, the lower part of the stomach is twisting along the axis of the long axis of the stomach organ. Coming to the diagnosis part, immediate diagnostic methodology is to do an X-ray abdomen. In X-ray abdomen, there are some classic findings. One is there will be a localized, clinically itself there will be localized massive distension of the upper abdomen, and in X-ray itself there will be high greater curvature of the stomach, and the greater curvature will be crossing the stomach border, and also there will be fixation of the loop regardless of the positioning of the patient. Even if you change the position and take an X-ray also, the loop will be fixed. And there will be delimitation of the ingested barium. If you are doing a dye study, the ingested barium will be limited towards the distal end of the esophagus. There will be tapering. And also the hiatal saculations or diaphragmatic hernias can be visualized when you see the left upper dome of the diaphragm. And sometimes the opacity of the spleen can also be deviated. So this is an X-ray film showing various presentations of gastric volvulus. In the first X-ray, you can see that there is over distension of the stomach with air fluid level, and the twisted stomach wall can also be seen. Two shadows can be seen. Coming to the treatment of gastric volvulus, acute gastric volvulus needs early identification and intervention to reduce the total loss of stomach, because if there is delayed intervention, it can even result in total stomach gangrene. Early gastric decompression helps in proper reduction of the volvulus. So immediately when we do laparotomy, our main aim is to delineate the normal anatomy of the stomach, detwist the stomach and also delineate the normal anatomy. And then we need to inspect the stomach for areas of gangrene or perforation. Along with this, we need to identify any other secondary causes also, like associated secondary causes like any CDH or diaphragmatic infiltration if present. We need to identify and resolve it. Main aim behind the first surgery is, one is to identify any perforation as it is if it is there. Second thing is to prevent further volvulus from happening. So whenever you are doing surgery, after retwisting the volvulus, if the stomach is viable, then we need to prevent further volvulus by doing an anterior gastropexy. So multiple bites are taken from the body of the stomach, and the stomach is attached to the left side of the abdomen towards the anterior abdominal wall, as we do in a gastrostomy, so that it prevents further episodes of volvulus. But in case of complete gangrene, then we have to do a total gastrectomy followed by an esophago-jejunal anastomosis. Coming to non-operative management, the non-operative management of volvulus comes into play only in case of chronic volvulus. There is no role for non-operative management in acute volvulus. In case of chronic volvulus, initially we can try a non-operative management in children. One is we can ask the parents to position the infant on the right side or in prone position with head and elevation, so that the head remains above the torso after feeding. So this allows for the dependent portion of the stomach to remain inferior to that of the lesser curvature, and there will be less chance for the stomach to twist on itself. So such an approach must be like always when you are attempting for a non-operative management, you should always keep a low threshold for intervention if child comes with any acute symptoms of acute volvulus, or if child deteriorates rapidly, then you should keep a low threshold for intervention for that child, because if any delay is there, then it can cause gangrene of the stomach and further deterioration of the child. Now coming to second pathology, that is gastric perforation. Spontaneous perforations are more common in case of neonates. Spontaneous perforations can happen mainly because of ischemic injury, which occurs in the perinatal period. And also there are iatrogenic causes also, like as if in upper GI endoscopy, there is chance for perforation of stomach, and also when we do excessive ambouing, violent ambouing can also fill the stomach with air, and in turn can lead to spontaneous perforation. So it can lead to iatrogenic perforation. And also in adherent NG tube insertion and pushing the NG tube too much into the stomach can cause gastric wall injury. And another cause which we have seen in neonates is fungal infections. In case of fungal infections also, there can be spontaneous perforation of the stomach wall. So mainly the spontaneous perforation happens secondary to ischemic necrosis. So ischemic injury happens during the perinatal period, and due to especially when there is perinatal birth asphyxia, and in turn hypoxic ischemic injury can occur, and there can be ischemic necrosis of the stomach wall, which in turn can present as a perforation. So usually they will present in around day 2 or day 3 of life. So other etiopathogenesis includes there can be a congenital muscular defect of the gastric wall also, which can predispose to spontaneous perforation. Then excessive bacterial colonization of the gut with pathological organisms also can lead to perforation, as in case of fungal infection. And when there is immaturity of the immune system, and also endothelial injury related to use of indomethacin are also reported as a cause for stomach perforation. Regarding the site of perforation, usually it is seen along the greater curvature of the stomach. And clinical presentation as such, it will be an abrupt abdominal distension, and it will be rapidly progressive. And child will develop respiratory distress because of diaphragmatic splinting. And day of presentation will be, as I said, because initially there will be hypoxic injury. By the time it perforates, it will be around day 3 to day 5 of life. And child can have signs of hypovolemia, poor perfusion, and also respiratory distress because of diaphragmatic splinting. So diagnosis clear cut in an abdominal X-ray. it will be showing free air under the diaphragm because stomach will be having too much amount of air. So the gas will seep into the peritoneal cavity and it will present in the abdominal Xray as free air in the under the diaphragm. Coming to the management as such, early recognition and prompt treatment is required. So immediately we need to do fluid restoration and also decompress the abdomen of the child so that respiratory distress will come down. So immediate glouder insertion or a needle insertion will decompress the abdominal cavity. And we need to stabilize the child with blood transfusion, correction of sepsis and acidosis, and administration of IV antibiotics. And you decompress the stomach with an orogastric suction. And only essential diagnostic studies has to be done because already diagnosis will be a clear cut when you do a abdominal radiography. And if child goes into septic shock, then child will require intubation and mechanical ventilator support. So after initial stabilization, we should plan for the primary surgical intervention. Immediately on in NSU bedside itself, we need to go ahead with a paracentesis because diaphragmatic splinting can occur and it can lead to severe respiratory distress. So it has to be prevented by either by putting a glove drain or by a needle insertion and decompressing the abdomen as an emergency step which you can do bedside. So intervention is emergency laparotomy through a transverse or a supraumbilical abdominal incision. The ascitic fluid has to be sent for the culture. Mostly in most of the cases, the site of perforation might be occult and it will be difficult to identify. And the usual site of perforation, as it will be along the greater curvature of the stomach. Whenever there is a perforation and ulceration or perforation, we need to freshen the margins of the perforation and need to debride it. And once you get the healthy margin, a primary closure can be attempted. In case of extensive necrosis of the stomach, in case of delayed presentation and all, sometimes a child might require a partial gastrectomy. And in that case, you can always go ahead with a Billroth 1 anastomosis. That is, the stomach wall is hello. In that case, the stomach wall is directly anastomosed to the duodenum. That is Billroth 1 anastomosis. Regarding the outcome of gastric perforation and intervention for gastric perforation, the survival rate comes around 75 to 80% in case of isolated gastric perforation. And in infants with gastric necrosis and in whom already ARDS and sepsis has already developed, then there is always chance for high morbidity and mortality because of ongoing sepsis. Thirdly, we will discuss regarding different techniques for feeding gastrostomy. So feeding gastrostomy, as we know, that it is a type of enteral feeding. The various indications for feeding gastrostomy is that when we are not able to replace the functional GI tract of the child, then in that case, and child requires prolonged nutrition, then we need to provide supplement nutrition enterally with the enteral nutrition technique. Contraindications mainly include an ongoing intestinal obstruction. When there is distal obstruction, we cannot do an enteral nutrition. And in case of upper GI bleed, when there is severe diarrhea or intractable vomiting, and if there is ongoing enterocolitis or severe inflammatory bowel disease, and also in case of any high output intracutaneous fistula. Now, coming to the advantages of feeding gastrostomy over other enteral feeds like feeding jejunostomy, gastrostomy is more physiological because you are directly delivering food items into the stomach cavity which has got an acidic medium. So it can tolerate a higher osmolar feed content when compared to jejunostomy. And also bolus feeds are possible, but in case of feeding jejunostomy, you have to go for a continuous infusion in order to prevent diarrhea. So gastric acid also helps in better digestion and has bactericidal activity. In case of long-term feeds, we will have to switch to a feeding gastrostomy, and we cannot keep a nasogastric tube in situ for a longer time. So other prerequisites for a gastrostomy is, one, most importantly, we need to assess the gastric emptying time of the child, and also we need to rule out a gastroesophageal reflux. One disadvantage with feeding gastrostomy is that aspiration risk is more when compared to jejunal feeds. So basically there are two types of feeding gastrostomy. One is a Stams gastrostomy and the other one is a Janeway gastrostomy. Usually we do Stams gastrostomy because it is always a temporary gastrostomy. And endoscopic methodology is also available. That is percutaneous endoscopic gastrostomy can also be done. So coming to Stams gastrostomy, in Stams gastrostomy, we do a laparotomy and identify the stomach wall, and we pull out the stomach wall through the laparotomy incision, and or the body of the stomach, you take a purse string stitch and you incise the stomach wall and insert a Foley's catheter and inflate the bulb and tighten the purse string along with it, and then you can fix the stomach wall towards the anterior abdominal wall as shown in number 5 picture. The stitch areas are also shown in that number 5 picture, and you will take multiple stay sutures over the abdomen and fix the anterior aspect of the body of the stomach towards the left side of the abdominal wall, and you bring the Foley's tube through a separate opening in the abdomen. So this is Stams gastrostomy. Directly you are entering into stomach and fixing it to the anterior abdominal wall. So by 2 to 3 weeks, a track will be formed, and then you can you don't have to like you can always change the tube also through the same track, and this a fistulous track will be completely formed. In case of Janeway's gastrostomy, it is more this we usually do when we require a permanent gastrostomy feed. So in this, you tubularize the stomach. The technique is almost similar, but in which in this technique or along the greater curvature, you take a part of the wall of the stomach and you raise it as a flap. You insert the feeding gastrostomy tube and then tubularize the wall of the stomach as shown in number 8 figure. You tubularize the feeding gastrostomy tube along the stomach wall, and this tubularized part along with the gastric mucosa is brought out as a fistulous opening outside. Now, third methodology is percutaneous endoscopic gastrostomy. Two techniques can be done. One, it can be a push-in technique or it can be a pull-out technique. In pull-out technique, we'll do an endoscopy. We'll inflate the stomach with air, and with light guidance, you can put in a needle into the stomach via the anterior abdominal wall. Because stomach will be inflated and it will be touching the anterior abdominal wall, you can insert a trocar or a needle, and through which you will pass a guide wire. This guide wire is again clasped by the endoscope, and it is pulled out. So once the guide wire comes out through the mouth, through this guide wire, you can railroad the percutaneous endoscopic gastrostomy tube. So that tube can be pulled out through the mouth, and through the esophagus it will be pulled out through the abdominal end. So once it comes near the abdomen, you can fix it with 2 rings. So it will be the stomach will be anchored towards the abdominal wall automatically. So without any surgery itself, you can do the same procedure endoscopically. Another technique is push-in method, in which you in the exactly opposite direction you will push in a feeding gastrostomy tube into the stomach and fix it using 2 rings towards the anterior abdominal wall. Complications as such, the patient can come back with clogging of the tube, and immediately in the postoperative period there can be, if the stitches give away, there can be leak from the stomach surface, and it can go into the intraperitoneal cavity. Another complication associated with gastrostomy is aspiration, because when you are initiating gastrostomy feeds, you have to make sure that you ask the mother or counsel the mother to keep the child in a head up position to prevent risk of aspiration. And in case of where gastric emptying is delayed, there can be high gastric residuals, and the food can pool inside the stomach, and in turn it can lead to aspiration. So if you are putting such cases, then you need to give patients with prokinetic supplementation also. Another complication with enteral feeding which can happen is diarrhea, and also there can be metabolic derangements. Metabolic derangements are less likely in case of gastrostomy feeds. It is more likely in case of feeding jejunostomy rather than in case of feeding gastrostomy.
Yeah. Sethu, I have a question for you.
Yes.
You heard about perigastrostomy leaks, isn't it?
Yes, sir.
How do you manage them? Suppose you've done a feeding gastrostomy for a child. Maybe imagine you had done a diversion for a patient with tracheocerebral fistula. You've done a gastrostomy, and the child comes back maybe some 3-4 months later with a perigastrostomy leak.
Yes, sir.
You've seen that, right? Common situation. So how do you manage that condition?
Sir, I think we'll have to re-explore the child, because the stitches would have given away and stomach would have come down and tract would not have completely formed. So
after 3 months?
3 weeks?
No, I said 3 months. Following 3 months, 3, 4 months, the child comes back with a perigastrostomy leak. Very common problem.
Yes, sir.
What we have seen clinically. Yeah. So how do you manage this condition?
Um, mm, Perigastrostomy leaks are, it could be due to tube blockage only.
Yes, that is one.
Yes.
So,
So
so what do you do?
we can change the tube
So
and
check for the patency of the tube, isn't it?
one there might.
So that is the first step.
Yes, sir.
Yeah, tell me.
Sir,
So
one.
that's the first thing what you do.
So first thing.
Now, suppose given that you have changed the tube,
No, sir.
okay, so you had put a 10 French Foley's catheter and again you change it to a new 10 French Foley's catheter.
Yes, sir.
The catheter is not blocked now. In spite of that, there is perigastrostomy leak. What to do now?
Sir, in, tube is patent, then also pericatheter leak is there.
Yeah.
Okay. Tube is patent.
See, Sethu, these tubes will have their own mind. They don't listen to you. Okay.
Yes, sir.
So this is what will happen always, sir. So you must know this, sir.
Yes, sir.
You can't say that, sir, still the tube is leaking, sir. How can that happen, sir? Like that. Every tube will have its own mind if it has a mind. Okay.
Yes, sir.
So keep your mind open. Don't close it.
Okay, sir. Sir, we'll flush the tube.
Reinflate the
No,
bulb.
he told no, he changed the tube.
Yes, sir.
Now what you will do?
Sir, we can reinflate the bulb and hitch the stomach once again towards the anterabdominal wall and then try.
Yeah, that also has been done. So in spite of that, it leaks.
Yeah.
Because if you exert excess tension against the abdominal wall,
Yes, sir.
okay, there can be that localized area of necrosis of the stomach. You should be very careful with that against hitching. Okay.
Yes, sir.
What is described? What is described in literature for management of perigastrostomy leaks? Okay, I'll tell you the answer.
Yes.
You need to shift to a smaller size tube.
Okay, sir.
Okay, so change the tube, but you put a new smaller size tube.
Yes.
So what will happen is the hole around the tube will be healed with granulation tissue.
Yes, sir.
Got it?
Yes, sir.
So that will stop your leakage. So what many people do is they think the hole is bigger than the tube and they try to put a bigger tube.
Yes, sir.
That's a wrong notion. Okay, don't do that.
Yes, sir.
So you change over to a smaller tube. Over a period of time, granulation tissue will seal that opening.
Yes, sir.
And the leak will stop.
Sir,
Okay.
that time we can continue.
Yeah.
Okay. Your point is very valid about putting a small size tube. I have not done it actually. It's new information for me. But till such time that the granulation forms, how does the leak actually stop?
No, it doesn't stop immediately, sir. It stops over a period of time.
Other option I have seen is to admit the child for a daycare admission. Keep the child NPO for about 4 to 6 hours. Remove the gastrostomy tube. Put a dressing there. Don't feed the child. Keep the child NPO. Within 4 hours, 2 to 4 hours, the tract will slowly contract. So put the same tube back in, and usually the leak will stop by that time.
Yes, sir.
What is the other common complication you have not mentioned?
Sir, following.
Child is being fed, but child will also have bilious vomiting.
Oh, sir, the bulb, if it is pushed towards the gastric outlet, it can obstruct the gastric outlet if you are inflated near the gastric outlet.
Bulb has gone into the duodenum, man, not the gastric outlet. So bulb has gone into the duodenum. So baby is fed nicely. There is no problem with feeding. But there is a gastric outlet obstruction with bilious vomiting.
Yes.
Correct, no?
Yes.
Have you heard of a Witzel gastrostomy?
Yes, sir.
What's a Witzel?
Which is feeding jejunostome?
It's a gastrostomy.
Same thing. The principle is the same.
Yes, sir.
So you bury the tube by a few sutures
Okay.
to a serosal tunnel
Yes, sir.
and bring it out to the skin.
Skin.
Okay.
Yes, sir.
So Witzel gastrostomy sometimes can be done to prevent the leakage.
Yes, sir.
Okay.
Okay.
A few other things I wanted to actually highlight about gastrostomy. Because generally, gastrostomy is thought to be a very simple procedure. May not be. For example, the placing the gastrostomy itself is important. For example, it depends on what is your further procedure. In case you're planning for a total gastric pull-up, it doesn't matter where you put up. Whereas if you are going to do it for pure esophageal atresia and your preferred choice is a reverse gastrostomy, it's better to place the gastrostomy near the lesser curve. So sighting gastrostomy is also important. Okay, one. Second, very common, commonest complication after gastrostomy is a peristomal leak and excoriation of the skin because gastric acid comes out. That generally happens because most of the times when we put a dressing, the Foley's catheter is what we use. We don't use a button very frequently. So if we use a Foley's catheter, we just pull it out and put a dressing. What happens is it doesn't stay put, it sort of moves around and maceration happens. So the simplest trick is to make sure that the gastrostomy, the Foley's catheter is pulled directly up the direction and is held. The best way is to prepare 2 bolsters of gauze pieces, place it by the side, pull the gastrostomy, whatever Foley's catheter, and fix it to that, so that the traction on the Foley's catheter is vertically up and perpendicular to the abdominal wall, so that it doesn't move around. Number 2, make sure that the traction is not too high. That's what I think Murali was trying to highlight earlier, that if you put too much traction there may be pressure necrosis. Okay, so this is one. Second option, what we used to do is simpler way, is either to put a safety pin in the bottom, that is without piercing the gastrostomy, take a big size safety pin, put it on the Foley's catheter by the side, and you can fix the safety pin so that it doesn't move around, so it is get fixed. Third alternative is to use the nipple of a feeding bottle. You can make either a slit or a hole and pass this and make sure that the nipple is placed reverse so that the flat of the nipple is on the anterior abdominal wall. So this also will help in making sure that the traction on the Foley's catheter is straight out. All right, so it doesn't move around. And the worst complication you can think of, the most important, what is the most important step in a gastrostomy?
Fixing the stomach towards the
Very true. Okay, so Sethu is across the board. I can tell he has given me the correct answer. Fixing the stomach to the anterior abdominal wall is the most important step, because if you don't fix it properly, then there may be peristomal leak and can cause peritonitis. I have seen this happen and it's a nightmare. Not accepted. Okay. Can you say something about the different types of tubes that can be used, including a Mickey button?
Sir, for endoscopy, sir, we can use one which we commonly use is a Foley's catheter.
What is the advantage and disadvantage of a Foley catheter?
It will get blocked easily.
Tell me the advantages and disadvantages.
Advantages, one, it is easily available.
Yes.
And cheap.
Yes.
Disadvantage is that the fixing part towards the skin, again it will cause excoriation and skin issues.
Okay. You can everything already. There's a Volvulus catheter, you can't fix it, you can migrate, you can come out, it can go inside.
Yes.
Fixing is a problem, peristomal excoriation is a problem, frequent blockages are a problem. Okay.
Yes.
In general, whenever you are doing other types where you don't want, for example, the times that we used to use a Melicote's catheter. Okay. Previously, we used to use Melicote's catheter very frequently, both for ICD as well as for gastrostomy. The commonest place where we used to find blockage was because the flower was there. So we used to sort of cut the flower and put the only the expanded portion. Can you do a similar thing for gastrostomy also? I will cut off the tape. See what happens in a Foley's catheter, there is an end hole. It's not a side hole, end hole, it's a side hole. And there is definitely a cul-de-sac beyond the side hole. So the tendency to block and concretion happens there. So can I cut it off?
In case of Foley's.
No, I'm using a Foley's, I can cut it.
Should be careful not to injure the bulb.
But
Yeah. Tell.
But bulb is proximal to the slit plus.
Yeah.
Yeah. One is some people do cut it, but when you're cutting it, like what Vinu was saying, you have to make sure that you're not cutting the balloon.
Yes.
That means you have to be beyond that area. One. Number two, it causes very rough edges. So insertion becomes difficult because tip is no more smooth. round. So again, reinsertion becomes difficult and to retain becomes difficult. So it's fairly cumbersome. So most of us don't do. Okay. Next question is about the Mickey button, gastrostomy button. So if you're using a button, when can you put it? What are the advantages, disadvantages? Mickey button actually is fairly straightforward to use. Okay, if you're going to use a Mickey button, the incidence of peristomal excoriations are much less. The chances of it migrating are much less. The chances of spontaneous expulsion is much less. And for the parents also, it's much easier because it comes with a pre-attached syringes and tubes, which can be used and taken it and used fairly easily. I'll give you a demonstration piece also if you want. It's fairly straightforward and easy. Previously, it used to cost very much, and now I think the cost is about 5,000 to 6,000 rupees. Not too expensive when compared to so many other things. So if it is a question of how we talk to the parents that they may take, for the ease of management, it is nothing like it. But the only disadvantages are, one, that it is expensive. So 5,000 may be expensive for some patients, but anyway, it's better that because lots of things what we used to be considered expensive become straightforward now. For example, once upon a time, we never used to apply stapler saying it is very expensive. Now you can't think of doing a Hirschsprung without a stapler. So things will automatically come up. So more than just the cost, I feel you need to put a filter of the ease and the convenience of the patients. So it's not just about this. So question of time before you switch over to Mickey button. The only disadvantage is that in India, we don't get the correct sizes. For example, there are two dimensions are important in a Mickey button. One is the diameter of the stem. Number two is the length of the stem between the flange and the balloon. I hope I am clear. Okay. So ideally, you are supposed to measure both and tell. For example, you are supposed to say 12 French 1.2 centimeter or 12 French 1.8 centimeter. Unfortunately, we don't have that much range in our country because the market is so small that they are not able to bring that much. So ideal way to put a Mickey's button is there's for a Mickey button measuring device. Basically, it's just nothing but the same size of a Mickey button, a long one with calibrations and measurements on it. So well lubricated one is put inside the abdomen into the stomach, inflate it, and you pull it out and measure the amount of what is outside. Here, very important is that the length of the stem may vary when the child is supine and erect. So best thing is to measure it when the child is supine and measure it when the child is erect. Keep the average between the two is what you should order ideally. One. Second thing is, in fact, I learned it the hard way is, for example, if it is a Foley's catheter, sometimes things are not available. Saline, you put a room air to inflate because it works as effectively. But this doesn't work in Mickey. If you put room air, it gets deflated. Okay. And another important precaution, whenever you say about whether it's Foley's catheter or a Mickey button, is to make sure that the parents have a spare one with them. So in case it comes off, they can be taught to put it back. In case that is not available, what the simplest thing I tell them is to put the same thing back, even if it comes out, say wash it, clean it and lubricate and put it back so that the tract doesn't close down by the time they reach you. Because sometimes it happens in early evening and they come to you next day, late afternoon, the tract might have been closed off. So it is better to ask them to put it back and come. At that time, they can try it with NGT feeds. Sorry, sir, I have told. Ramchandra, sir, Murli, Ravi Kiran. Yeah. When will you come? I need to talk to you. I need to talk to you.
Sir, Ravi Kiran here.
Yes.
So one point I want to make, while reinsertion of a tube, especially in a neonate, we need to be very careful about the length we put inside before inflating the balloon. We need to make sure we just put very little inside. As soon as the balloon is crossed, inflate, or else there are chances it can go into the esophagus and then you inflate the balloon in the esophagus and cause injury. That is one thing when you change it in a neonate.
Yes. Volvulus and perforation.
Other thing is laparoscopic gastrostomy is also an option.
Sir.
And also you can do a appendico gastrostomy, especially in a patient who has had a malrotational surgery being done. So the appendix and the cecum and the appendix will be very close to the stomach. So very easy to do an appendico gastrostomy, especially when it is a long-term or a chronic gastrostomy requirement.
Yes.
So when you want a mucosal lined gastrostomy, you can do an appendico gastrostomy. or a Monty's tube also has been described for a gastrostomy. Okay, especially if the stomach size is very, very small, post-volvulus or something like that. When you're left with a small remnant of the stomach, you cannot bring that stomach up into the abdominal wall. So you can do an appendico gastrostomy, or you can do a Monty gastrostomy for that.
Yes. Now that you talked about the lap gastrostomy, any idea about lap gastrostomy, how it is done?
Not seen. Not seen.
Yes. Closer to the mic.
Sir, anyone has experience with lap gastrostomy?
No, I have just read about it. I think Ramesh might have done one or two,
Yes.
maybe more. I'm not sure.
Not very many, because the indications are fairly less. That's why, because many times the gastrostomy is done mainly in newborn areas. The gastrostomy that I've seen basically is described by Keith Johnson, in which he uses a U-stitch gastrostomy. That's what he says. I've seen many being done by Jorgensen himself when I was there with him. So under a 5 mm, what is done is they put in a umbilical trocar, put another trocar to catch the stomach, identify where you're going to place the gastrostomy, bring it near the abdominal wall. Then place a percutaneously placed U-stitch. That is, it goes to the anterior abdominal wall, takes a bite on the anterior abdominal wall and comes outside. 2 such stitches are taken, something similar to what you do for a falciform ligament during a pyloromyotomy. So percutaneously you are taking basically 2 U-stitches and taking that to the abdominal wall. Then they put in a Viris needle or something and get it into the stomach. Once that is there, then they put a guide wire through that and dilate the tract. Once the tract is dilated, then they put in the Mickey button. They used to put a Mickey button, and then the 2 hitch stitches they used to fix it to the abdominal wall. What I have done simply Desi modification is, I used to find it difficult to get this dilators and other things to put in a Foley's catheter. So what I have done in a couple of cases is to put a simple hitch stitches, bring it up to the abdominal wall, make a small cut and a suprapubic trocar and cannula. Put a suprapubic tracker into the abdominal wall, into the anterior abdominal wall, anterior stomach wall, put in the Foley's catheter, inflate it and take out the suprapubic catheter. Suprapubic catheter, cannula. The advantage is that it is easy and available. The disadvantage is a lot of wearing, because the moment you put that, it is uncontrolled. So most important thing, I think the lesson that we learned was to be quick, and that everybody in the team should be clear that once the moment we take it, we're going to put it in a shot, we're going to put it before we have to put in the Foley's catheter, inflate and pull it. So in a couple of cases, I was not happy with the anterior abdominal wall. So what I've done is laparoscopic needle holder and use the stitch to the anterior abdominal wall to the anterior wall of the stomach to make sure that doesn't leak. Meeting is good.
What I have read is, Ramesh,
Sir.
the technique which is described
Yes, sir.
is a 5 mm optical port at the umbilicus.
Okay, sir.
Okay.
Yes, sir.
This is done in a situation where you are expecting a lot of additions. You don't want to do a peg. You are likely to go through the colon or small bowel or something,
Yes.
on your path to the stomach.
Yes.
So important to put an optical port first. See inside. If there are clear path, then don't put another port.
Okay.
If there is a problem, then you put a 3 mm port.
Okay.
Or a stab incision for a 3 mm instrument to clear off the additions.
Okay, sir.
Okay.
Okay.
And then where you have marked for the gastrostomy, you put a 5 mm port.
Okay.
And through the 5 mm port, under vision with the optical port,
Okay.
you use a tooth grasper.
Okay.
And pull the stomach up where you have marked where you want to put the gastrostomy. Pull the stomach up.
Okay.
Pull the port out.
Okay.
And pull the stomach out through the port incision.
Okay.
Once you have grasped the stomach,
Yes.
you put say a suture on the stomach to the rectus abdominis.
Okay.
Or wherever, whichever fascia. So you put 4 or 5 sutures like that, anchor the stomach to the abdominal wall.
Okay.
And then put 1 pursing suture.
Okay.
And then in the middle of the pursing suture, you insert say a Mickey balloon or a Foley balloon or something.
Okay.
And finish off the gastrostomy. That is how they have described.
Excellent. No, I got it. So in fact, I've done the similar technique for one child. Robert will remember. Basically, a gastrostomy. This is fundoplication in a mentally retarded child for whom a gastrostomy is also needed. So finally, this is what I did. I delivered the stomach outside, put a stitch and put it back. I think it's a simpler and simpler to do it, sir.
Yeah, correct.
Thank you, sir.